Okay. This is Mark. Say hello, Mark. Hello, everybody. He does fabulous software. Right. Thank you for your forbearance. It's 5 past and we'll get started because I know you'll have trains and things to catch at the other end, but apparently you've got some drama on the railway lines. A train has arrived on time and it's thrown everything out. So we don't know what to do. Okay, what's different about me?
Oh.
Nice.
You've shaved? You got plain socks on?
Yes. Yes, I've been lasered within an inch of my life and now I can see you all. And I never realised all these years what I was dealing with. Okay.
You looked in the mirror.
Yeah. Yes, and I'm so pleased with what I've seen.
Well, that hasn't changed.
We were going to hear from our sponsor this evening, but I don't think we've got time now. Anyway, listen, it's great to see you. Are we live on Periscope?
Yeah.
We're live on Periscope, so everybody at home, thank you very much for tuning in. We've got fabulous guests tonight. And but first of all, a word from the fabulous. I know you all look forward to this bit more than the interview, really. It's the unbelievably fabulous Michael Thick. Come on, Michael. He's got a very short. I know. Okay, no. So there's not time because stand there.
Oh, in Periscope, am I?
Yeah.
It's a great pleasure to welcome you, Peter. Have your torch lit to become one of the Illuminati of this event, and to suffer the withering attention of Roy, which we all do, as you know. I guess it must be quite hard to be at the top end of the, not perhaps the most popular organisation in the world. I think as sponsors, we'd just like to say, how come as part of the CQC measures, you don't have the presence of an IMS information system?
That was our sponsor. Okay, right, well let's find out then about this man who's thrown his career away to become the chairman of the CQC. Ladies and gentlemen, Peter Wyman. Thank you. Peter, thank you very much for joining us.
Right, can I just say, it's really good to be here. You and I don't agree on absolutely everything. I have noticed that some of your blogs aren't undiluted praise of the CQC. But I think it's really important that you and I do agree, and I think probably everybody else in the room will agree, that for patients and people who use social services, knowing that those services are safe, effective, caring and responsive is really important. So the opportunity to discuss with you tonight CQC's role in all of that, I really welcome, so thank you.
Right, well that's got the bullshit out of the way. Now let's find out what really is going on. Actually, you've got I think you're a very interesting guy. In fact, you're the kind of a guy that my old director of HR would have said, do not employ this man because he's never stayed anywhere for long enough. You've done a huge amount, haven't you?
I was going to say, well, I did do 42 years at PwC, so your HR
but
director may have thought that was quite a decent stint.
Well, that just shows you, I think that just shows you lacked ambition. We're being taken over by people from PwC, have you noticed? Yes, we've got Ed Smith who's at the PwC. I met a couple of chairmen the other day who were at PwC. We've got a gentleman in the audience who was ex-PwC.
It's good fun.
You think, is it kind of Freemasonry thing? What is it?
It's just a good firm, with good people, and good people get to the top, right?
Is that? I never noticed. It's never happened to me. So, where were you born? Where did it all start for you?
So I was born in 1950, so I put that right on the table. And
you're not, but a lad.
We lived partly in Surrey. My dad was a consultant anaesthetist at the old Westminster Hospital, which is now part of Chelsea and Westminster. So we lived in Sutton, but my mother's family were Cornish, so as a kid all my school holidays were spent in Cornwall. Fantastic. So half in Surrey, half in Cornwall.
And that's now it kind of, now I can link up the geography because you were chairman of a trust, weren't you?
I was chairman, when I left PwC I became chairman of Yeovil Hospital, which is a relatively small DGH in Yeovil, surprisingly enough. And I did that for 5 years, which was great fun.
Were you there in the sort of halcyon days when they were really, the integration thing was the name of the game, wasn't it?
Well, we were I think ahead of that curve.
Yes.
Although obviously people can talk about integration forever, but we were really clear that the future of a small DGH is a self-standing organisation was distinctly limited, and therefore we needed to join up. We did a lot of work with university to establish what the future demand was going to be, based on what we know at the moment and assuming no population migration. And the conclusion from that was that if nothing changed, the hospital was going to have to build and staff a new ward every year. Completely impossible, by the way. It was never, even if you had the money, it was never to build it, let alone find the staff. So that tells you that's not possible. The other piece of work we did was to look on an anonymised basis at the drivers of cost of the NHS and where they fall. And no surprises came out of this, but it's all about the number of comorbidities. And the more comorbidities you have, the greater the cost. And it's not just a simple straight line. It gets, with 5 or 6 comorbidities, the cost of looking after you, keeping you alive, is enormous. And the bulk of that cost falls on the acute hospital, unnecessarily. So those two things together told us that we really need to start doing things in a very different way. Partly the integration became the first vanguard for the primary acute care integration, partly about reorganising things that were happening in the hospital. The other lesson, which I think is quite important, that we took out of that is just how long it takes to do these things. These are not quick solutions, these are complex things you're dealing with. So by the time I left, we'd made progress. I've been gone from there for a year now, and they've made further progress. But we always said that it was a period of about 10 years from start to getting to where we really needed to go to. Interestingly, the money falls out of the tin. You get back to break even at the end of that journey as a system as a whole. You move the money around. Strangely enough, the hospital would need slightly less, and other parts of the system would need.
But that's the difficulty, isn't it? Getting people to look at the money as a global, as a global. We've got a chairman here from the Isle of Wight tonight, Eve Richardson, and they've been talking about the Isle of Wight pound, trying to get people to look at the funding in a global sense, which is, I suppose, really you were the start of what we now call an accountable care organisation, which in my day we called a district health authority.
Well, what comes round goes round, as you rightly said. No, that is absolutely part of the ambition. To become an accountable care organisation. But the number of people that need to sign up to that, is quite a lot, and of course it goes across both social services and the NHS.
And it's the pressure on primary care, isn't it? Because on the one hand, the doctors are in fact later in the year. Is it in April, John? Where we've got a guest from the Royal College of General Practitioners, Helen Stokes Lampard, I think is coming.
Thank goodness she got that.
Yeah, I've got I think it's the first time I've ever got anybody's name right ever. I don't know what it's.
25th of
It's Lampard. It's a footballer, isn't it? I mean, she's related. Do you think she's related?
I wouldn't go.
Your first question, when she gets here.
Think we can get
Not one I'm after, I have to say.
Can we get any tickets? I mean, on the one hand, she's saying, the primary carers are the lowest of the low and blah, blah, blah. And on the other hand, you've got Simon Stevens talking yesterday about getting primary care to do more. And there's, 23 million going in, no, 2.4 billion, isn't it, going in by 2020, which might be too late.
Well, I think this is a race against time, because what we are seeing is demand going up as the population ages. Going back to what I was saying about the multiple comorbidities, more of us are living longer, but we're not living necessarily in good health for a lot longer.
Aren't we being unnecessarily gloomy? I mean, I think there's a whole cohort of people coming through that are certainly older, and they do have comorbidities and all the rest of it, but the baby boomers are yet to really start coming through the NHS, and the baby boomers have had a better diet, they've had a better education, they're net savvy. I mean, we might be dealing with an entirely different cohort of people.
Well, we might, although I'm not quite that optimistic, but funnily enough, I think there is a lot of light at the end of the tunnel.
Well, you were born in 1950,
Yeah, it's a good time to be born.
A bit late, maybe. But no, I'm born in 1950. I mean, the baby boomers are the sort of 60s, aren't they? Really? I mean, if you look around at people who are born in their 60s, they don't have all the problems that my mother's generation had.
Yeah, but I think what we're going to find is that we do live longer in good health, you know, and 50 is the new 40, and 60 is the new 50, and all of that. But there will come a point when we're still alive that it will catch up with us.
Yeah.
So I think in a sense the last few years have been a bit misleading, because that there's a generation of people who previously would have been with these, well, they'd either be dead or they'd be quite sick, and now they're alive and well, but they are about to come into the system. But actually, I do think there is light at the end of the tunnel. I think we will make integration work, because it is so obvious, and it'll have to be made to work, and that will help quite a lot. But the other big thing, Roy, is technology. I mean, I've talked about this. This technology has the ability to be transformational.
It's never kind of fulfilled its potential, has it?
Well,
you know, there's so much. If you just look around in life normally, right? I mean, I was saying I just had this laser surgery, and now they gave me an app on my phone. Right? I've got a complicated regime of drops to put in, right? And they've got to be put in at a certain time. So they've given me an app.
Mm-hmm.
It's got pictures of the drops that I've got to take in the bottle.
That's why you had the laser surgery.
Yeah, so I can see. Yeah, exactly. They have it in braille for where it fails. But they've got a picture of the bottle, right? Yeah. And this morning I had to take, I had to do one set of drops, 2 different bottles, right? At 12:37. That was when they wanted me to take, right? 12:37, and it beeped. And I didn't do it, and he beeped again. And he got angry, and then I did it and pressed confirm, and he left me alone. I mean, so that kind of technology is around. And we talk about compliance with pills, and what do? We give people a POSIT box, you know, and then wonder why they forget.
Yeah, so you know, that is changing.
Do you think it is?
Oh yeah, but we all know that all technology, people underestimate the time it'll take for it to have that big impact, and then they underestimate how bad that. Well, that's why I say, you know, there is light at the end of the tunnel.
Well, you see, is it a train coming the other way? I mean, we had Simon was good enough to be. It's been twice actually, Simon, and we had a bit of a laugh because he was saying, "Oh, it's the 5-year forward view and all that." I said, "No, it's not. It's a 200-week forward view. He's only got 200 weeks." He went away. Do you know what he's done? He's so crafty, that boy. He's in March. He's recalibrating the 5-year forward view.
But so I go back.
God knows what it's going to be now.
So this is not a train coming the other way. But the point I was going to make was, which in the sense you were making, is that it gets worse before it gets better. So
how much worse is it going to get?
We've got us about, well, demand is going up about 6% a year. You know, it depends on what part of the system and what part of the country, but you know, that's sort of roughly where we are. So until we either find a way of managing that demand better, or putting in much more resource, it will just go on getting worse.
Well, I mean, it's a resource issue, isn't it? I mean, in the year 2000, right, we were putting 6.3% of GDP into running our health services in the year 2000, right? Blair came in and said, we've got to put more money in. He upped at that time they were putting about 3% per annum extra in each year. He upped it to 5%. He got us to the European average, which I think at that time was just about 8 point something, or just under 9% GDP. Now, next year, we will be putting in 6.6% of our GDP. I mean, there is just not enough money going in.
So that's why I say what we've got to do is really put our foot on the pedal to get integration happening more quickly, and to get you really start using technology, and you know, I think those two together will make a dramatic impact, but it's not going to happen overnight.
Okay,
let's
think
about
about
agreement.
Well, I don't know about that. Let's find something to argue about. I mean, integration. You know, everybody says, "Oh, integration." Okay, if we merge, I wrote about this morning. If we merge health and social care, we have to overcome the issue of social care being means tested, and healthcare isn't. And I know there will be people who say, no, you can still, you can merge and you can still have different departments and all the rest of it. But we know there'll be a porous boundary. And before you know it, social care, something from healthcare is going to be, that's actually part of your social package, love, and before you know it, people are going to be means tested for little nibbly bits of healthcare, and the whole thing starts to do a transition. I used to be a big advocate of merging health and social care. Now, two turkeys don't make an eagle. Nobody's got any money. And to merge, I think, is dangerous. I'm now campaigning not to merge.
Good. So we found something we can disagree on.
Right. That's great. It wasn't difficult, was it?
So I don't see any alternative. One way or another. I mean, there are different ways that you can achieve this. But you have to
What's
find...
that called? The Better Care Fund?
Well, you've got to... Well, that didn't quite do what it was supposed to do.
Lucky dip.
Yeah. But go back to the research that we did, and this is relatively scientific. That if
How
you,
dare you?
If you take some, if you can move the money to where it is most needed, you achieve two things. One, you actually provide better outcomes for people, because you don't want to be in hospital unless you have to be in hospital. So the whole starting point needs to be you're only in hospital for the acute episode when you need to be there, and then after that you're either in your own home or in a nursing home or wherever is the most appropriate place. That's one end, but the other end, which I think is not talked about enough, is stopping people arriving in hospital in the first place, particularly stopping them arriving in an ambulance, because they've waited until they reach the crisis point. And the
You
only
can't
thing
get an ambulance, they go on the bus.
Well, they do get ambulances. They arrive in A&E, and 9 times out of 10 they will be admitted, and once they're admitted, they're there for quite a while. That is really bad for the person.
Well, you see, I don't get this. I'm not sure I agree with that. I mean, if you need an ambulance, you need an ambulance, don't you?
Yeah, sure. So the point is, don't get to the point where you need an ambulance.
Well, then that's often really not within our purview, is it? That's a social care thing.
The point I was trying to make to you.
It's a family thing.
Yeah.
There's all there's all kinds of reasons why.
You're making the case better than I was.
Really?
Yeah.
Damn it.
But seriously,
he's outwitted me.
But seriously, that is the point. And so, we don't want people to get to the crisis point where they do need to be in A&E and they do need to be
Okay, well, we know. Look, you take your average granny. You know what happens. They get up there on their own. They get depressed. Don't make a cup of tea. They don't drink enough. Get a UTI. Get giddy. Fall over.
Yep.
We find them in a heap. 3 9s into A&E, the most awful place you can put your confused granny, and it all kicks off from there.
My point exactly.
3 weeks later, she's still in hospital.
Yeah.
Now, okay, what could we do about that? Well, we could have healthcare assistants popping in every other day to make sure they're all right, looking for decline, and trying to head the stuff off at the pass.
Yeah.
But what that does, Peter, is it changes the fulcrum point of healthcare. It changes us to a prevention system rather than a fix-you-up system, which they've talked about since the day and hour that Florence Nightingale and I used to come to work on a bus. It's absolutely, and we're supposed to. What are they saying? 2% of the £30 billion of the savings by 2020 is supposed to come from prevention. I don't believe it.
But in principle, what's not to like about?
Well, nothing. But I mean, you can't bank a principle. I want to hear the money rattling in the tin. How are we going to save 30 billion quid in 200 weeks' time by farting about with principles?
So
discuss.
That's not a question that I can answer. That's not my bag, as it were. But what I do know from where we were in Yeovil when I was there was that we had a proof of concept and we were working exactly down this road, and it will get delivered and it will produce
Well, you were
savings.
certainly the pin-up boys at that time.
It'll produce savings, but more to the point, it'll also produce better outcomes for people.
Well, I absolutely
so that's
agree.
where
But
we've
I
just got to push this road.
Can't see how we get that. Well, I
Gotta
agree
get
with
there.
that.
Gotta get there.
And when we get to this nirvana where every little bit of the NHS is integrated and joined up and wired, how the hell are you going to come along and inspect it?
No, I don't think that's a particular problem. There will still be bits that are essentially primary care. There'll still be bits that are essentially social care. There'll still be bits that are acute care. So a lot of what we currently do, we can do with the same people in the same way.
But you're poking about in fridges looking for out of date. I mean, come on, let's get real here. You can't carry on with the model you've got, because it's too labour intensive, it costs too much, it really hasn't worked very well. I mean, we've been inspecting now since, what is it, 2006, and 70% of hospitals are in some kind of trouble. I mean, if inspection was going to work, it would have worked by now.
So I think there are about 4 points there that you're making. Just to finish on inspection, as it integrates, then we can flex the inspection model to fit the integrated model. So that I don't have a problem around that.
Do you think you can?
Yeah, definitely.
You can't get inspectors now, can you?
Yes, we can. We've got the inspectors we need, but the core competencies don't change. That's my point. You join it up differently, you may manage it differently, but the core competencies aren't changing, either from health or care professionals or from us as regulators. So I don't think I really do not think that's an issue. Can I just pick you up on your point about fridges? I don't know why you lighted on that, but I'll just tell you a story, Laura. There was an inspection we did just before Christmas of a GP practice. And one of the many problems, or a lot of problems in this practice, one of the many problems was that there was no control over the fridge temperature.
There's a thermostat.
No, and it wasn't working, nobody was checking it. Consequence was that all the vaccines were no longer safe. And in consultation with Public Health England, everybody who had been vaccinated had to be revaccinated.
Oh, I saw that story.
Yeah. Now, if we hadn't looked at the fridge, the only way that would ever have come out would have been if a whole lot of people, frail elderly people, who'd had a flu jab, who thought they were safe, all got flu and some of them died. Then there would have been an inquest. Then it would have been found. So coming back to about prevention, actually that simple thing of looking at whether people were controlling the fridge temperature properly, really important. So I do think inspection works. Now, I'm not quite sure where in the cycle of life 2006 was, but as far as I'm concerned, CQC, as we currently know it, started in 2013. And everything before that is failed history. So we can agree that it didn't work. My predecessor, David Pryor, was very clear. CQC, when he came in 2013, wasn't fit for purpose. David Bean talks about if there were special measures for a regulator, it would have been in it. That was then. That is a very different story now. I think the last 3 or 4 years of inspection are working. We are finding things. We are also driving and encouraging improvement, which is a pretty good place to be. So I reject the notion that inspection isn't working. I accept it didn't work in the past in the way they should have.
How do you address the point that just about any, and you're from a management consultancy background, how do you address the point that, I mean, all the great sort of management theorists and others all say, I mean, right back to Deming, they'll all say that inspection is no way to achieve a quality product. Why does the CQC think that inspection works when almost everybody else that's ever looked at organisational methods and structures and all the rest of it say, do you know what, it doesn't work. You've got to get whole system response right.
So both. I don't think it's an either or. I think it's both. But I think there is an element of inspection that is really important. There are certain things that you can't find any other way. I've talked to, I went a little while ago, it's interestingly, I went to talk to the nuclear industry regulator in the United States. This was after 3 Mile Island and all the dramas and so on. I said, look, you guys are potentially, it's seriously dangerous. How do you regulate this industry? How do you make sure it's safe? And interestingly, the answer was using data, as you'd expect, but also a very intensive inspection model. And I haven't spoken yet to a regulator in any industry, in any country, where inspection isn't part of the model. But there is definitely another part, which is about using data effectively so that you can start to be more clear. And we're having a conversation about this earlier in a slightly different context, about where are the looming problems and get in before they become
I know, yes,
yeah.
I mean,
So
that's why I thought your point was
yeah.
refreshing, because
Yeah.
I know you get that in turning up with a clipboard and a charabanc full of people and spending £50,000 in a local hotel is not really the best way of doing it. But if we look at the data, such as it is, we're a long way, really, aren't we, from being able to capture the real-time data, even though it's possible to do it, even though the technology exists, even though, you know, if we wanted to, we could set up a hospital with all kinds of data points that we could look at in a real-time basis.
Yeah, yeah.
We're nowhere near it.
We've got some of it. You're right. We're not where we should be. As hospitals and the other people that we regulate start to use data for their own purposes. I mean, if you and I were running a hospital, Roy, we would want those sort of systems for our own management, not for the regulator. We want it for ourselves. And I think more and more hospital managements are looking at how they can get that real-time data. Once they've got it, then sharing it with us is really straightforward.
You could drive it on, couldn't you? You could actually say a term of your license will be that by 2018, 2019, we will be able to get real-time data on this issue or that issue. You could make it happen.
Well, I think there's also a carrot approach, which I prefer, which is the more data you give us, the more we are either comfortable that you haven't got a problem or comfortable that you've spotted the problem and dealt with it, then the less intrusive and
well, look, I mean, just think, you're like everybody else in the NHS, your budget has been reduced, and we all understand that, and now you're charging people for inspection and so on and so forth. I mean, there's a lot of things to spend money on, there's a lot of priorities, and I mean, I don't think, my view is, I don't think it's going to happen unless you make people do it. And you could make people do it. You could drive on technology by making it a part of a license. I mean, the same way, for example, in care homes, for example, you know, a lot of care homes are, you know, on the margins of being habitable. You could drive improvements on a lot more by making things like, for example, a qualified nurse on every shift, or you know, something. You could drive on improvements by saying we won't license you unless you do this.
Well, to some extent, of course, that's what we do all the time. But in terms of technology and the investment required, I'm not sure that that's the best way. I think the better way is to make it in their interest. I mean, what I'd like to get to, let's talk about care homes for a minute. What would be really good would be that care homes were A, profitable businesses for people who are running them, because that's important, and B, really safe, decent places for people to live in. Part of achieving both those goals is to have the ability to say this is a safe place. So if you and I, Roy, in our dotage, choosing a care home for ourselves, we would want to be confident that it was a good home. We'd be comfortable that we get our meds when we need them and all that sort of stuff. So I think there is a commercial driver for care home owners to get to that point, and I think that for their own use of technology, their own confidence they've got the right levels of staffing and so on, then getting a good CQC rating, which again becomes a commercial benefit to them. I think that's the way to drive this improvement.
Well, I just think it's going to take such a long time to do it.
Well,
If you look at it, what are we losing? One care home a week, aren't we?
So
is that right?
So I don't know.
I think it is. We're losing. Hang on, just to make the point. We're losing one care home a week, mainly because the rates that local authorities are paying are insufficient to make the thing a viable business. So what are the care homes doing? Well, they're cranking up the private payers. So local authority person in a care home is what's about 385 quid or some unbelievably low amount of money. Private people going into a care home, you're looking at $1,250 to $2,000. So the private sector is subsidising the public sector, which is an interesting way around. But a lot of the sustainability. I mean, don't you get to a point really where the CQC has some influence, and you say, do you know what? We've got so many care homes who are struggling, and they're not producing a very good quality of service. As much as we'd like to think that some do and some don't, by and large, it's a money thing, and until that's sorted out, we can't expect the care homes to be better.
So I think that's why we were very clear in the state of care report
Senior,
where we said we think that adult social care is approaching a tipping point.
What sort of response did you get that?
Well, this is a report.
This is a report. I know you're all across this report. It's really quite an interesting report. Yeah.
This is a report that goes to Parliament, and the intention.
They're accountable to Parliament.
Yeah, good. No, it's good to be clear about that.
Not the punters, Parliament.
And so what we wanted to do was to stimulate that debate in Parliament, and that's happened. So I think it's amazing how many times you hear people talking about the tipping point, and we were the first people in this context to use it, as far as I know. I think what's interesting is that nobody has challenged what we have said.
No.
So you know, the issue is out there, Roy. Now the question is, does anybody step up to the plate? So to get to a really good market solution, you get to a point where private punters wouldn't use a home that wasn't good or outstanding as rated by us, but also nor would local authorities commission into homes that weren't good.
I think local authorities will dump grannies wherever they can.
Well, we could be, kind of, because there aren't, in many parts of the country, there aren't enough beds, so they do that. But if they had a choice, between a good home and a bad home, they'll choose a good home. I'm not quite as cynical as to think they would deliberately put people in bad homes.
I think
there's a market that's got to work.
You've got to be realistic. They just look for beds, don't they? I mean, and today, you know, we discovered that the CCGs are putting up the threshold on nursing care beds, and now they're saying if a domiciliary care is 10% more than going into a full-time nursing home, which often it is.
So I mean,
you know, we're going to scurf your granny out of her front room and bung her into a home.
So, you know, as we said in the state of care report, we have to get adult social care properly funded to an extent that people who use those services can get access to good services, not necessarily just the private payers, to your point. But secondly, it then starts to take some of the pressure off the NHS. So there's a win-win.
Yeah, but it's a common mythology, you know. When we say, oh, hospitals are full and it's all because social services can't do care packages, it's not true. In November, 57% of people who were marooned in hospital were in there at the reason, fault, however you want to describe it, the fault of the NHS. 34% were there because they couldn't get a care package from social services. It is not true that the logjams are created by social services. It's contributed to. Fundamentally, it's inefficient hospitals.
So there's, as I said earlier, there's three contributors. One is that people are coming to hospital when they don't need to, or at least wouldn't need to if there was adequate care at home or in their own place of residence. So that's a big.
Do you look at length of stay when you inspect?
And
what do you do about that?
Well, flow through the hospital is something we would very much look at. So your second contributory point is inefficiency in hospitals sometimes. But the third point is.
Well, it's the majority of the time.
Well, the third point is a very, very strong point. It's not untypical at the moment for something like 10 or 15%, and in some cases even more than that, of the acute beds being occupied by people who are medically ready to go home. That's a heck of a proportion. Both very costly because the hospital is a more expensive place, but as I said earlier, it's also not where they want to be. And then in the context of this, those beds then are not available for emergency patients, or they are available to emergency patients because, or other beds are available to emergency patients because all the non-emergency surgeries had to be cancelled. And this is really bad. I mean, you know, nobody has surgery as a sort of lifestyle thing. You know, people have surgery even if it's not an emergency because they're in pain, they need a new hip, they haven't got the mobility they want, their quality of life is damaged. These operations are having to be cancelled, not because there isn't a surgeon, not because there isn't a theatre, but because there isn't a bed for them afterwards.
Well, we all get that. But when your lot turn up at a hospital and they've got 9 or 10 ambulances outside, A&E looks like Armageddon, and all the medical wards are bunged up with your granny, and half the surgical wards as well, because there's nowhere to put anybody. Is that hospital well led?
Probably not. I mean, it's a bit of a generalisation, but on your description, probably not.
So what does the chief expect?
Well, it's interesting. Well, because it's interesting, isn't it, that you can go to some hospitals that are absolutely outstanding in the way they manage this, and they're not in catchment areas or that are particularly wealthy. They're not in wonderful new hospital facilities, but they've got fantastic systems to flow people through the hospital. They've got a degree of integration. And so the whole thing works. So well led is both have you managed to join the dots with the other parts of the system well, and are you working in partnership well, but also actually have you sorted everything out inside the hospital. So to give you an example, I went to Luton and Dunstable the other day, a few months ago, which we rated as outstanding, and particularly outstanding in its emergency department. So they have, I may have got this number slightly wrong, but something like 110,000 attendances a year. 30,000 of those.
2,000 a week.
30,000 of those go to a GP practice that's on the site. So they never actually touch. So all your miners don't touch A&E unless for some specialist reason they get referred across. But it's all on the same site. So
Is it a GP surgery or is it GP trial?
In this particular case, it's a GP surgery.
Do you have to be registered?
No.
So how do you?
So you just arrive at the hospital.
Okay. How's that funded? How's it paid for?
It's funded through the commissioning, through the. It's effectively a walking centre.
Yeah.
So I mean, there are different models. I mean, you're right.
Interesting enough to illustrate that point. A couple of weeks ago, there was a survey in the Times where 500 GP practices. It was only 500, but nevertheless, and I don't know how they were selected. But 500 GP practices, 62% of them said close the surgeries, put them on the hospital campus.
Yeah.
Well, that was GPs. I thought that was really interesting.
So do I, because most of us don't distinguish between whether we're seeing a GP or an emergency physician. We feel safe because we've arrived at the hospital, and we have confidence that once we've got to the hospital, we'll be put where we need it. So I think there's a really big thing around that. But going back to,
do you think that's developable in other hospitals? Yeah,
of course it is. And I've talked about Luton and Dunstable as a particularly good example, but it's not the only example.
But primary care sees 1.3 million people a day. That's huge scale. We couldn't shift that to secondary care.
So just sticking with how Luton and Dunstable works. So that GP practice on the hospital site is open. I think I'm right in saying 18 hours a day. And they looked at whether it needed to be open 24, but actually the additional demand through that 6-hour period wasn't sufficient and wasn't putting a burden.
Doctors needed to sleep for 2 hours.
Yeah, sometimes. Yeah. So that was the first thing. So about 30% of people who otherwise be in A&E don't come to A&E. The other thing which I find incredibly impressive at Luton is the way they flow through the hospital, and they've got some software which I just thought was fantastic. It's really smart, so they can tell from the moment that you're in the ambulance. From what the ambulance crew say is that you'll be arriving, you're male, you're almost certainly going to need a bed, and you're going to need a surgical bed. So from the moment, we haven't even arrived yet, they're trying to find you a bed. Yeah. So by the time they've seen you, assessed you, and occasionally they'll find, well, actually you don't need a bed, that's even better. But by the time they've assessed you and you're ready to go out of A&E, there is a bed with your name on it. It's there because I was moved out very promptly. Because they're also very efficient working with the community to get discharged. So they knew by the time you were in your ambulance that I was going to be ready to be leaving at about the same time. So my bed became yours.
I mean, I think that
really
software
smart.
is
really smart.
I think
really smart.
I think it's fairly common. I've seen it in several places.
Yeah,
but
it's not.
It's a fairly small catchment area. Luton and Dunstable has a fairly healthy young population.
It's not. It
doesn't have.
It's a pretty deprived part.
Well, there are bits of. But everywhere you go, there's bits of it.
Yeah.
But if you take that, putting a GP in A&E or whatever, however you want to do it, that if you just deluge with numbers and you can't get people out of their beds, whether it's the fault of the hospital or the fault of social services, you can't do it.
So I keep going back. various parts of this prevent people from getting to that point of crisis.
Yeah, no, I get that.
And
But the point I'm coming to,
is
the point I'm coming to
Yeah.
is that you're doing what Jeremy Hunt does, and a lot of other people do. They say, well, because one hospital can do it, everybody else can do it, and you can't.
Why not?
Of reasons of demography, reasons of staffing, reasons of all. I mean, you know the reasons.
I don't accept the premise. I absolutely accept that some of this is difficult, and I also absolutely accept the point that I think you were making a minute ago, that different people will have slightly different models of how they do this, and that's fine. So what works in your area, but the principles will work everywhere.
I think there is room for best practice. If you
Yes.
look at ESIST, for example.
Yeah.
The emergency care, whatever it is. What is it, Terry? Emergency care, something ESIST, I don't know what it stands for. But if you look on the Academy website, if you look at the Academy of Fabulous Stuff website, look at ESIST, ECIST, they've got some fantastic routes through the system, flow.
Yep.
They do the red and green days thing. They're adopting best practice. And that, again, for me, really is one of the failings of inspection, in that you turn up and you say this place is no good and walk away and mark them down. There isn't a real good mechanism to say this place is crap and we're going to stay and help them not be crap.
So what we don't do is that last bit, right? But what we do, which you
isn't that quite important?
No, because other people do that. But what we do is say, here are the things that we would recommend you as the board, because you're running the trust, not us. Here are the things that we would recommend you do, and one of the things may well be
sack the chief executive.
No, that's not something we'd say. What we might say
Did it
is
to Keith McNeil?
No, we didn't.
Somebody did.
Yeah, people who run the trust. Come back on that in a moment. Let me just finish this point. What we would say is, there's a hospital like you might like to go and talk to them because they have got a way which might have some applicability. We might say, why don't you call in ESIS, because we think they would be able to help you. We do try and point people in the right direction. So I think there's a lot of positive stuff comes out of inspection, and it's important. I mean, part of our remit is to encourage improvement. It's not to do what you've just described. Let's just quickly kill the issue of Cambridge. Yeah.
Fantastic place.
I agree.
Much loved chief executive.
Well,
some of the best outcomes in the NHS.
And a hospital that which was absolutely a great hospital, and is again, that had taken its eye off the ball. That was the conclusion.
I think it was a really subjective, rotten.
Well, you may think that. Some of the senior staff there, Roy, have actually thanked us for doing it. We said it was a wake-up.
They're all brown nose round the CQC.
No,
because they try and keep you, stop you going there next time.
No, they're not.
Yes,
I wish they were. It'd be nice if they were. They're not. So
if I was running a trust, I'd crawl under a worm's belly to stop you coming.
I stick by this. Of course, it's a great hospital doing some great things, but it had also taken its eye off the ball, and particularly taken its eye off the sort of DGH part of their business. And ours was a wake-up call. They turned it around, and so all of that's history.
And he was such a bad chief executive. He's now got a role in NHS England helping other hospitals.
So just
somebody stabbed me.
So just be clear why he left. Was nothing to.
We know. I interviewed him. He sat there and told us.
And what did he say? I sacked him.
No.
Not because I didn't.
No, he didn't.
So what did he say?
He said that he felt very let down by the whole of the events, and he went through a whole catalogue of stuff that he did, and he did not at all, in one iota, agree. What he said, in fairness, what he said was the place wasn't perfect, but to be condemned in the terms that it was unnecessary and unfair. And that does bring me really to quite an interesting point in the way that, I mean, you template your reports really quite tightly, and I understand you want to do that for uniformity purposes. The inspectors are always anonymous, so if you look at care homes, for example, you can't connect with the inspector to have some kind of relationship with them about improvement and so on. I mean, in the old days, you probably remember, we used to have CHCs, community health councils, where, and I know, it's easy now to look back and turn your nose up at them, and they did become politicised, that's true, and why Milburn got rid of them. But it just seems to me there is no local connection with what you do, And I mean, when you ring up, you've got to go to your call centre. You know, the public ring up and say this is terrible, and say thank you very much, we'll put it in the mix. It just seems to me to want to have this kind of brittle exterior of bureaucracy. It's not a very warm and friendly place, is it?
So, again, there's about 10 points in there. I'm trying to unpick some of them. So, yes, we use templates. I mean, that's just an efficient way of doing this. But
it doesn't allow for nuance, does it?
Well, it does, because let me just come on to this. So that's a starting point. That's not the finishing point. When I came into CQC, Roy, which was just about a year ago, as you know, one of the things that I did worry about was whether there was consistency, because we always have a lot of inspectors. These are individuals, and they're teams of individuals. But did good in Brighton mean the same as good in Bolton, as the same in Birmingham? And that worried me a lot. One of the things I did fairly early on in my days at CQC was to sit in some of the meetings where the evaluation takes place. So that starts to move away from your template, which is the starting point, to something which is much more nuanced, but it's also really challenging. You've said that, what's your evidence for saying it? You've said that in this case and came to that conclusion, in that case you came to a different conclusion. So let's be absolutely rigorous in making sure we are consistent and clear. So that was one of the points we're making. A second point is that we go out of our way in our reports to make a big comment on things that we find that are really good, because I think that's important. I mean, there are very few hospitals, because they're big organisations, where everything is bad. So even in hospitals that we put into special measures, those that are the worst hospitals have got pockets of great things happening. So we try and signal those, because I think that's important. I think it's important that these are the judgments of the Commission, not the judgments of an individual inspector, which is why we don't go to who was the inspector, but it's not exactly a state secret. The trust knows who's or the provider will know.
Well, everybody knows everywhere, that's true.
Yeah, so
I think special measures actually is a good place to be right now, because nobody expects too much from you. They get off your back, you might get a few extra quid, and you might get some management support. I think if I was a trust chairman, I'd aim for special measures.
So that would be good the short time you stayed as a trust chairman, but unless you actually sorted it out, Roy, I suspect your board would say, come along, it's time to move on. So, I mean, but you are right. I mean, seriously, you are right that special measures does bring with it support.
Yeah,
and that is important.
Great. My advice: get in a special measure.
And what is also good is that we are not seeing the majority of hospitals going into special measures and staying there forever. There is a nice turnaround. It doesn't happen immediately. I was talking to one where this is happening, and it's a lot of heavy lifting, but they get there. So
very subjective. Listen,
I've
got an eye on the time. Who's got something they want to ask? Who would like to ask? Gentleman at the back. Yes, who arrived on a bicycle, really, dressed up in neon, a bit like an ice cream cone. Yes. You look like me when I'm on my bike. Yeah, go on, far away then.
Well, I'd like to go back to what you said about inspection, and I don't know much about management theory, but I was very interested here. Most management theorists don't think inspection is up to much.
That was according to Roy.
It's true. It is true. I mean,
I can't find anybody that supports that.
That's not true. Edwards Deming, Porter, Charles Handy, Tom Peters. I mean,
Tom Peters was all about management by walking about.
Yeah, but that's not inspection.
Of course it is.
No,
it's a form of inspection.
No, I've interviewed Tom Peters.
So have I. Yeah,
it's not true.
So good. We'll compare notes later on that. Not David, your question.
Well, obviously you succeeded with this cupboard full of vaccines that were being kept at too high a temperature. And I'm sure that there probably are successes like that, particularly in the medical world. But when you get over to sort of social care, where the crucial thing is not how, I mean, it's important, but it's not the crucial thing, is how the medicines are kept, or whether the hot water is too hot, or that kind of thing. The crucial thing about social care is that these are people's homes where they are going to spend the last of their days, and they need kindness and compassion. And your commission never, virtually never, finds out that horrible things, cruelty is happening. It didn't find out in the Morley homes in Cornwall. when we saw on Panorama these two nurses talking in a cruelist way about their patients and treating them cruelly, giving them chemical crushes. You didn't find that out. Now, I quite agree, inspection obviously isn't going to find out. You turn up in the morning and they are not going to behave in that kind of way in front of you. Although occasionally they do, like in Hinchingbrook Hospital, that was one case. But anyway, normally they won't. But what you don't do, it seems to me, is to encourage the friends, the families, the people who know about what is going on or who suspect that things are bad in the hospitals. You do not encourage them to come to you, and they don't come to you. They go to Panorama or the local press or the Daily Mail. And that is simply because if you ring up your customer care centre, all they will do is perhaps say nice things to you, and then they will file it away and look for trends. And people who ring up places like that want action. Now, I know you can't deal with individual cases, but you can make the local authorities do something serious about it. And you don't. And nobody trusts you to do anything serious about these sort of things. If people were doing this sort of thing, then and giving you this kind of information, then you would really be able to do targeted inspections, and you would begin to be the ones who actually found the cruel care which you are not finding at the moment.
Peter, let Peter respond. I mean, there is, we'll deal with that directly. There is an issue about engagement with the public. You're right, and I have to say there's an issue with engagement with the public and complaints and worries and concerns right across the NHS. We had the parliamentary ombudswoman, sitting here, and she gave the most pathetic answers to that. If you complain to a trust, you get defensive letters. The NHS is not easy to complain about, and I think the point that you make about the call centres is often made to me.
So I think 2 points, David. I slightly disagree with you on your first point that getting your medicines when you need them isn't important. It is really important. You said it was less important. Well, I'm not sure I agree with that. I think it's really important. I think it's equally important because you probably die if you don't get the right medicines or you're in pain or whatever. But I absolutely agree with you that this is somebody's home, and you've heard Andrea speak as the Chief Inspector of Adult Social Care on this frequently. This is somebody's home, and therefore it's really important. And I do agree with you that a whole lot of people will be aware when they go into a home whether this is a good caring place. A lot of professionals, you talk about friends, family, that's certainly important groups, but also professionals that go in and out. And I absolutely would encourage, and it's one of the key planks of what I want to do, is to get more people to talk to us. We do take action, and if this is being broadcast, Roy, it would be great if people would hear this, if nothing else, that I'm saying tonight. We do take action. We have to decide how urgent that action needs to be, but last year there were 3,000 or thereabouts inspections that were what we call reactive inspections, so they were based on information, sometimes from staff, sometimes from visitors, friends.
How bad does it have to be?
Well, it's question of really how immediate the risk is would depend on how quickly we would feel necessary to do something, or how severe the risk is. I mean, it can be as instantaneous as it's possible to organise.
Well, I mean, if you say, you know, I went in there and I saw a nurse beating somebody up, you call the police. But I walked into a care home and it stinks of urine.
We would be there.
Which often do. They do.
Yeah.
They often do.
Yeah, we'd be there. We'd be there very quickly, because that's telling you all kinds of things. So absolutely, first of all, everything that comes into it.
So let me see how this works, because hang on, this is very difficult for me to get my head around, because frequently people say to me, I wanted to complain, I rang the call centre, I spoke to somebody and they just kind of fobbed me off and said they'd make a note of it and pass it on. Step one, is there something about training your people in the call centre to appear to be more responsive and more reactive? how is it worth explaining now how it works from the call centre point of view? So I'm Roy Lilley. I ring up and I say, I've been to see my auntie. I haven't seen her for ages. She's lost a lot of weight since I saw her last. The place stinks of urine.
Okay, so I've sat in on at the call centre. I've sat in on calls from the public to understand from both ends, if you like. So the first thing is to try and assess how urgent the risk is. And if it is a safeguarding risk, then there really does need to be immediate action, either by us or by some other authorities. You say it might be a police matter or whatever. And we have a protocol, and that will be dealt with.
So
within
what happens?
within 24 hours.
I can smell urine. I walked in the front door. I smelt urine. I don't think there are enough staff there. They're rushed off their feet. What would happen?
So in that case, it would go to people who understand and know about that particular home, and we'd correlate that with other information we've got, and we would respond with whatever degree of urgency comes out of that. But we wouldn't ignore it, that's for sure.
Supposing it said, supposing you went back and the last report said this is a well-run care home, well-led, and we've scored it as being, whatever. And here we've got strong smell of urine, and my auntie's lost weight.
So
what would you say? Well, maybe that's just a one-off. There's not a trend here, or the other way round. This is the 5th complaint we've had about this place in the last 3 months, or whatever.
So we'd certainly look at both what we'd said before and whether there have been other complaints. The loss of weight is potentially very serious. I mean, I'm not saying that the place smelling of urine isn't serious, and it probably is an indicator of all kinds of other things. So we wouldn't just file that away, Roy, but we might not say that needs to be dealt with within 24 hours. If you added to that you saw somebody being attacked in some way, something like that, then that's immediate.
That's an entirely different matter.
So we get about 90,000 calls a year, and
how big's your call centre?
I couldn't give you a number, but it's quite large. It's up in Newcastle. It's very good. They handle those. There's no delay.
Are they your own staff, or is this?
So they work on. They're trained. They work, as with all call centres, they work on screens that give them prompts, so they know when they need to call. This is a police matter. This is a whatever. It's really. If you come and have a look one day, well, it's really good.
I will. I should write about it. Who's got another question? Let's move on. Yes, sir, and I'll come to you.
I have so many.
Okay, well, we've got the room booked till 11 o'clock. So.
Couldn't take that long. Well, for a start off, I mean, I wear a number of hats sitting here because I've been involved with CQC on the receiving end of care with my parents. I'm an operator. I've been in the care business for 30 years, and I've seen the CQC and I've seen its predecessors and the way that the whole regime.
You remember CHCs?
I remember local authorities, loan CHCs. Yeah. So, first of all, you said many things about the CQC tonight. Particularly, just talking about that one issue about the call centre. It's obviously a big issue. You've got a call centre. It's got a lot of people there, and I can give you one example of my experience of it when I rang, and I made clear to the CQC when I rang them up that I was concerned about the provision of care in one of our NHS hospitals. My father was in there, and I got a very nice letter telling me that, very interesting, but not very interesting, it's if you want to make a complaint, you should use the hospital's complaint procedures, which I found quite surprising because I didn't want to make a complaint at all. I wanted to provide some insight to the CQC about some quite serious problems that existed in that NHS hospital. Not because I wanted to criticise the NHS hospital or give them a hard time, but because I wanted them to understand how to improve those problems that they had. I felt that the CQC's responsiveness to that was pretty appalling. And I imagine that's been the experience of a great many people.
Yeah, I mean, I think it's, I'm not trying to not have you ask a question, don't misunderstand what
I can go to another question.
Yeah, well, yeah, because I mean, I can't expect Peter to defend an issue that he's
I
not
wouldn't
seen.
ask him to, but it's an overall thing.
But I'm going to say, I write my e-letter, it goes to 300,000 people a week, and I get the major complaints I'm getting now, and I measure a lot by how people respond to me. The biggest issue I've got at the moment is safe staffing from the front line, and the other is the CQC. And Peter knows that. I've given up with the CQC. I just write a nice letter back and tell them, I can't do anything about it, but it's the top of my postbag with people complaining, and a lot of it is around how do I complain, and you can't do that.
But your point, if I understood it, was that you weren't trying to complain.
No, I was trying to alert you. That's
Yeah.
exactly the right word.
Yeah.
Not to create a problem. I knew that the CQC was going into that hospital in the not too distant future, and one of the most important things is to have an understanding, because the CQC inspectors don't see everything. They need information. They need intelligence.
Is the issue?
They need to gather that.
I'm going to stop you there, I will come back to you because I know you've got another question. But the issue, if I triangulate that experience with the experiences that people write to me about, I think the call centre, which is not clinically led as far as I'm aware, but trained call handlers, which is fine. Call handling is nothing wrong with call handling if it's done properly. Maybe there are some issues at the call centre to look at around responsiveness and authenticity. Is it an authentic? Are they authentic when you ring? Let me come back to you.
Can I answer the
please
question?
do. Yeah.
And then I'll
yes, of course.
Then I'll answer yours.
Yeah.
So I think you were trying to alert us to your concerns, and that undoubtedly would have been fed into the inspection, and that we may not have said that, and we may not have agreed with it. We may not have found what you found. I have no idea. But we wouldn't have ignored it. So
you could have done it with the information that you asked for, because you didn't get the full information. If you'd have actually wanted to do that, you would have needed to ask me a lot more questions. I had a lot more information. So I got brushed off, and I was told I should write a complaint.
Well, that shouldn't have happened, because exactly what we want to happen is people doing what you were doing. But we do also get a lot of people who are wanting to complain. And maybe we just misunderstood.
Well, I explained that I was an operator and I had a clinical understanding.
Okay, in the interest of asking tonight, I will come back to you for a different topic.
So I think the call centre, do come and have a look at the call centre, because I think it's absolutely
I think I should come and have a look.
Sure.
But I had someone, I remember it very clearly, because eventually this bloke rang me up. He said he rang up the call centre and said, I want to complain about such and such a hospital, and the call handler said, we don't deal with complaints, right to the hospital.
Well, that's right.
You said you have 300,000 calls a week.
No, I write to it and I get 300,000 readers.
So for the CQC to manage that information is very difficult, and have a call centre, no matter how good it is.
No, I don't. I write an e-letter that goes to 300,000 people.
Well, I don't know how many complaints you.
But when you
we get about 90,000.
90,000
a year.
A year.
Yeah.
So not that massive.
It's quite it's quite a lot.
When you think of the billion, well,
it is a contact centre, so some of those are calls and some of those.
But you see,
probably me ringing up asking other questions.
Right, the difficult we've got here is and it's not entirely your fault.
Oh, thank you.
Because not entirely, because we exposed this before. It is impossible to complain about the NHS. You write to hospital and complain, and you get a letter back, dear Mr. Lilley, I'm so sorry to hear that in the case of your mother recently, our standards fell below what we expect of ourselves and your expectations. We've taken on board what you've said, and we've learned, and we'll do everything we can to make sure it doesn't happen again. Thank you for writing, bugger off.
So
that's the letter you get.
So you are spot on. There is a difference between wanting to make a complaint, which is not something CQC deals with. Okay, so you may not like what Julie Mellor said when she came here, Roy, but that's ultimately where complaints go if they can't get sorted out in the hospital or wherever it is. What we want is information that alerts us to the problem, and if we misunderstood what you're trying to say, then I'm sorry, because that was a missed opportunity.
You might need to look at the way you gather.
Stop. Let's move on. I'll come back to you. Yes.
Some kind of form.
I'll come back to you. Be a gentleman.
Thank you, Roy. Catherine Galbert. I'm wearing two hats this evening. I'm a non-executive director of a private hospital, and I'm chair of the Housing Association, both of which are in special measures.
Mm-hmm.
Which is slightly unfortunate, and there may be a comment not
Yeah, I was
made.
going to say, yes, what the common fact
I'm
is.
wondering, not a great any day. You thought there was something else, love?
So I've been really interested
Yeah.
to hear what you've been saying about your model of inspection, because being on the receiving end of two very different models has been a very interesting experience. And my observation is this: CQC come in and inspect. They take a long time to write a report. It's then very detailed and very critical. And I'm afraid I can't accept your observation that you do say nice things about in your report, because that's tiny compared to the very long list of things that you found wrong. You then give us 10 days to respond. And the process feels incredibly micromanaged, because the level of detail that is gone into and the level of specification about what we need to do differently is very high, and creates an enormous workload on top of what already is an enormous workload. By comparison, working with the HCA, my housing association is in special measures, not through anything that my board has done, but for historical reasons. We inherited a problem. The HCA's approach is, this is what we've observed, this is what we think you should be doing. Tell us what your remediation plan is. You take responsibility for that. We will comment on it. We will comment on everything you're doing. And if we're not happy that you're doing it, we will intervene. But actually, we think you're grown up and you're bright people. It's your responsibility. Get on with it. And our interaction is maybe twice a month. It's very strategic. It's very high level. It's very mature conversation about the issues to do with running a business, engaging stakeholders, providing high quality services, and modernising an organisation that needs a lot of work. I have the luxury at the moment of being working with both of those, and it's really interesting.
Yeah.
I just wonder whether maybe CQC might think a little bit more about the latter than the former, because it compels people to get on with what they need to do.
So 2 or 3 points. Firstly, I totally accept that it takes too long to get our reports out, and we are working on dealing with that. Although, as you all know, we would have given you key points more or less immediately. But your general point, yeah.
But
So
there was a difference between the key points.
there will be a lot more. There will be a lot more. I mean, by
And so
definition,
yes.
yes.
I'm sorry.
Yeah.
You know, you spend then 4 weeks
Yeah.
thinking, oh, well, that's okay, and that's not, and then the report comes, and it's actually far more critical than.
Yeah. So the
It
immediate.
does take a long time.
No, it does, and you know, I've just said. I mean, I absolutely accept that.
But you've been a
it takes too long.
year trying to sort out the speed of the report writing out, because being confessed ages ago, isn't it?
So we are dealing
Still
with this.
clinging on to
We're
his
dealing
job.
with this in 2 stages, Roy. The first is with existing processes. How can we help get the reports done more quickly? One of the bottlenecks has been the very process that I was so proud of, and so proud of, that ensures consistency. That's been the bottleneck. So
We need
we'll
more
deal with that.
inspectors.
We'll deal with that. We don't actually. This is not the inspectors that are the issue there. But the second issue in the longer run, and it will not be done overnight, is that as we become a digital by default organisation, including all the interactions that we have with providers that make life easier for them, but also the whole way we go about collecting information to inform the reports, how we gather the information during the inspection, and how we write the reports. Now that is not something that if we had this conversation in a year's time we would have fully implemented, but that's the direction that we will go as quickly as we can. So I you know, mea culpa, we are too slow in getting these reports
What
out.
is the problem with getting the reports out? Because this has been a complaint for ages.
Yeah, it is, and
what's the issue?
Well, it's the complexity. I mean, if you look at a hospital, it's a massively complex organisation. There's a lot of information that's gathered that needs to be then put into a report. We then need to go, and I just said that part of the bottleneck is we then need to be sure we're being totally consistent. So that takes longer than it should, and we will take some steps to speed that up using existing processes. When we get to a point where our inspectors are working off a digital platform, then actually that will automatically speed things up. That will be the breakthrough as far as we're concerned, to get the reports out much more quickly.
What's a digital platform?
So it's moving away from paper and just having everything on a connected.
Well, they work
system.
from home now, don't they?
So we have a register,
Yeah.
and all the information that we hold about any of our people we register is on that register. So the first thing is to have a much more modern register. I mean, I was on the board at Companies House. We've done that, and it took a long time, but it's fantastic. Much simpler, by the way, bigger volume, but much simpler than what we're trying to deal with. So you start off with all the information going into a modern computer, if I can simplify it like that. But for you or as a hospital, instead of sending us paper and we send you paper back and so on, I mean, everything you want to tell us about, changing what you're doing or whatever, can all be done in the modern way, Roy, where everybody else in the world operates. Yes?
If you don't mind me saying, I would really like you to address the second part of what I was saying, which is about the strategic level. But I have to say that is done digitally. That is done by email with the HCA. There's no rocket science.
Well. There's no rocket science about email. There's no rocket science about email, but there is rocket science about having the engine of CQC in the future becomes a fully digital register. It honestly will make it easier for you, but it also makes it easier for the public to get information, which they will want from us. It will speed up both the preparation of the inspection process, because just think about, going back to the earlier conversation, we've had people that have been telling us about issues they found when they were patients or visitors in the hospital. We've got staff telling us things, we've got public information, we've got clinical data, we've got non-clinical data. All of that has to be assembled, and at the moment it's quite a laborious task, so that's just automating all of that, to use a different phrase, and making it much easier both for providers to work with us and also for
How will
the
you
public.
do that with less money?
Because most of the cost these days doing these things is a revenue cost. It's not a capital cost, and this will save money. So it's just getting ahead of the curve so that we can invest to save. So that's all factored in.
But you do need. I mean, you do need a jumping off point. When the CQC was born, from the Bristol baby debacle. Alan Milburn really at the time. The decision to inspect was a political decision. It's not a management decision. Nobody in management would inspect and try and improve quality. It was a political decision. He then put together a system, really, which was based on a clipboard and visits, because it was the only thing at the time. The narrative has now changed, because we can do all of this much more efficiently in real time by using, as you call it, the digital platform. My question is, how do you make that leap? Because I can't see it with you're shrinking the size of the organisation because you don't have the money you did. The inspectors I talk to say they have too much of a caseload and they've got time to write stuff up. There's still a logjam in getting your reports out. And we've discussed this. The first guest we had from the CQC, I forget who it was, Mike Richards, wasn't it? I think that was a year ago, and he was talking about the same thing. And I'm not being critical, because you've got the day job to do, and moving into your digital platform is on top of the day job. I can't see how you'll make that leap.
Okay. Shall I come back and answer your question? I haven't forgotten. I've only answered half of it. But to your point, right, so this builds in massive efficiency. It creates time for inspectors to get on with inspecting, and I don't accept there is no role for inspection. But that apart, I agree with what you just said. At the moment, it's a very old-fashioned manual process of getting information, going around, collecting it during the inspection, writing it down, and then pulling it all together, turning it into a report,
We get
checking its accuracy.
How do you make the leap?
So the leap is just to automate all of that. so that inspectors have the information. They have it on this is not rocket science, to use your phrase. So they can have it on an iPad or similar handheld device. They have a template. They have the information. They can write there and then, and it sorts it into the first draft. And it's only the first draft of the report, cutting out massive amounts of labour-intensive work, improving accuracy, certainly speeding up getting out the reports in the process. So, but for two reasons, it's not something you can do overnight. One is the point you're absolutely right to make, Roy, that we've still got a day job, so you can't just stop everything for a year while you do it. You've got to do it in parallel. And secondly, we've got to get this absolutely right. And as you well know, the NHS is littered with IT projects that haven't worked. This is going to be one that does work.
Surely
So it will work. So, but it will take us some time.
Right. Are you satisfied with your answer?
Is there a loose?
Can you type that loose then? Because I want to finish up. We've got to finish at past. Can you?
I mean, very quickly. I mean, the approach that you're talking about is in part anyway the approach that I think we have, and I'd like to discuss with you when we've got more time. But certainly, I think what we're trying to do is say, here are the things that we think need fixing. Here are some suggestions about things you, the management, might like to look at. We don't come back in a week time or 2 weeks time or however frequently, but it's absolutely got to be your plan to deal with it. And if you're in special measures, we'll be back fairly quickly to see how you're getting on, and not to do a complete re-inspection. That may be necessary at some point. So in principle, I think we're doing what you're talking about. We may not be doing it as neatly as we've got experience in the housing association world. So I'd love to talk to you about that.
Right, far away.
Thank you. It's an absolutely fascinating dialogue here and interaction. I declare interest as an occasional CHC inspector, as a member of the public. I wonder to what extent, given the sort of comments about the lack of sort of real-time response, the CQC is learning from other longer established regulators like the Health and Safety Executive, whose inspectors can actually take people to court and actually do have to respond in real time. And you've got memorandum of understanding in that regard. But two other declarations of interest. I used to chair a CHC in the last century, and I'm an NED of an organisation that just
wasn't
been
that long
inspected.
ago, surely.
It was. Just been inspected by the CQC, and just very lastly, observation. What I've heard this evening convinced me that Joseph Heller, having written his first novel, went on the right NHS complaints procedure. But the question about learning about other regulators.
So I absolutely. So I mean, I do talk to other regulators in other industries. In this country, I talk to health regulators and other regulators in other countries. Very much want to see what we can learn, and I wouldn't like you to go away with the thought that we never respond quickly. As I said, it's a judgment about how urgent the response needs to be. If we deem it to be urgent, it is immediate or thereabouts.
Would it be worth publicising that? I mean, someone's come out this evening. Would it be worth publicising that? So
Yes, please, Roy.
People who don't get caught up in the system might have a lesser chance of doing so.
I think you're right, and I tell you what, I mean, I often get people who write to me about their complaints. Do you know what I say? Give up. You'll get nowhere. You'll spend the next 10 years of your life and you'll have a pile of paper that you can stand on and reach the ceiling. Give up.
But you would be doing, going back to the question from here, you would be doing them a favour if you said, if you have come across an organisation where you think there's an organisational issue, do tell the CQC.
Only if they've taken notice.
Well, yeah, but we
Yes,
will.
we go to this gentleman.
But we don't deal with individual complaints. So that's the
this
issue.
is a much wider. This is a much wider.
Yeah. Sure.
Sure. I honestly say to people, if you're after compensation, get a lawyer, but you may not have the money to spend in this lifetime. If nobody's dead and you're reasonably fit and well and you're just complaining about something relatively or important to you, but in the scheme of things, don't bother. Don't bother complaining about the NHS because it's impossible to make anything stick. And I'm a professional. I can't do it. Yes, sir.
I'm a coordinator for a local mental health network. Our local health watch seems a bit nervous trespassing on your inspection territory with their enter and leave individual units, because they seem very wary of it.
What a cracking question.
Yeah,
That's worth a round of applause. Come on. That's a great question. We like that.
Well, let me see if I can get a round of applause for the answer. I mean, we do think that local health watch is really important, and it is part of the eyes and ears that feeds into CQC inspection. We've got Health Watch England, which is the sort of coordinating body, absolutely trying to encourage through Health Watch England and the new chair and director there to make the local health watches feel empowered.
I think you need to talk across. I think you need to talk at regional level direct to the local health watch.
Sure.
Because I'm not sensing that message coming any more than NHS England's aspirational messages tell people what to do at the bottom.
Okay. I mean, I'll take it away. We've got a brand new chair, and we've got a brand new, I mean, literally started a couple of weeks ago, director for Health Watch England. So I'm going to make sure those messages are fed in, because it is, you're spot on. It's really important, really part of our
I think that's a very important point. Yeah. Never crossed my mind, but it's a great point. Okay, now I'm going to give you a second go. Okay.
Thank you.
On the understanding, on the Queensbury rules, right, that you're brief, because we've got to wind up.
I'll try to be.
Well, I tell you, you're going to be, because I've got the microphone.
So in the conversation we've been having, you talked about the digitisation and the need to have a proper basis for inspection. And from my experience, that's been very hit and miss. I've got experience of very good inspectors. Very often they're solo inspectors that seem to work very well on their own, and then the experience of an invasion of inspectors at a larger facility. And after a great deal of debate and argument with CQC, we obtained the records of the inspection. Those records were, to put it mildly, pretty appalling if you were going to try and write a report off the back of them. We got a pretty appalling report. We were found inadequate at that facility, which I, to this day, would debate very strongly.
Can you get to your question?
Yeah, but the question is, when you talk about digitisation and organisational in these inspections, what are you actually going to do to ensure that the inspections, A, have the proper information from the original inspection, and then when it comes to problems, as the sort of problems that we had, you have your reviewing process, but it's poacher turn gamekeeper. You have your, although you might have other inspectors, it's very much people checking their own homework. There's no proper regulation of this. It's very much a sort of, the CQC check everything, and there's no openness to it. And I think that's a huge flaw in an inspection regime, because people out in the wide world, the patients rely on what you do. Now in our facility, we have mental health patients. They were horrified by what the CQC had to write about our facility. It certainly wasn't the experience they had. It caused them.
Now I'm going to stop you there. So the question is, you're judge and jury in your own court.
Well, I think there was a prior question to that, and that was how does this work? So,
what the structure of the inspection is very flawed.
What I envisage is, as I said earlier, that an inspector will have on an iPad or something similar, preloaded before they arrive, all the data that they need. So that would be past inspection report, anything Health Watch has said, anything a whistleblower or a member of the public or anybody else has said, that's all fed in, as well as the basic information about the service that they're inspecting. And then it runs through a series of questions. Really important is that we don't end up in a sort of tick box. It's quite clever the way that you can, one question can either lead you to another 5 questions, or you just bypass the next 5 because you've got the right answer and jog on down. So you've actually collected it all, and the software can then order it into the right way, so that you end up with as I said earlier, the first draft of the reports is just the data that you've collected, organised in an efficient way. All recordings, it's permanently there.
So this is what your new system is going to do?
This is what we will move towards. Yes, it's not what we're doing at the moment. We try and do that, but it's all in a
it's chaotic with paper,
pen and paper age. Yeah. Exactly so. So I think, to the earlier question about the length of time on reports, this will speed it up. It'll speed up the accuracy. It'll minimise the risk of error. It'll make the inspections more more joined up, particularly in large complex organisations where you're really struggling with this massive data and papers and putting it all together. So I think it will be a big change. But the other part of that is as I said, the register becomes a really useful source of information to us.
What's the register?
Well, that's you register, as you know, and then some of that information is put on our website. So the fact that you're registered, what you're registered for, what we found when we inspect, that's all on our website.
So that's what you mean by when I think of a register, I'm thinking about an inspection register.
Oh no, absolutely not. So I'm talking about the register of registered providers, and our website is very good and easy if you know exactly what you're looking for, but it has limitations, put it politely. So part of this will be to restructure the website and make it much more useful. So if you're trying to find out which are the good care homes in your area, or in an area where you want to put an elderly relative, it's not your own area, for example, or whatever, it'd be much easier to search.
I'm going to move you on to marking your own homework. I mean, your accountability is through a report in Parliament and the Select Committee, perhaps every so often. That is not really accountability.
I think it's quite a tough accountability. I mean, having been there, Roy, I can tell you it's a real accountability. There are appeal processes, so people can either appeal to different parts within CQC, or if the whole process is flawed, and ultimately, and I hope this never happens, people can go to judicial review. So I mean, there are processes beyond.
It's very expensive.
I mean, I said it should never come to that, because there are internal appeal processes, and I think we are open and honest with ourselves. And if we've got something wrong, we will.
But you can only appeal, can't you, on matters of fact. You can't say we disagree wholeheartedly with this inspector's judgment.
No, and nor should you be able. Well, you can say you disagree, and absolutely people do. And we say if you disagree, then you put that on your website. What you can't do is somehow get our judgment changed because you disagree with it. But
you might be wrong.
Well, we might be, but there are a number of fail safes. So we do go through, and it's the same organisation to your point, but there will be different people. So if you're not happy with our report, then somebody who wasn't involved in the original inspection will look to see whether they.
But that's a kind of self-regulation.
Well, no, it is to a point, and then I accept that.
I just want to make one
right, hang on, I'm going to stop you. Look, I'm going to squeeze you in quick.
One very quick point. Who sense checks some of the recommendations coming out? We've just been through a very positive CQC experience, and because there was a lot that came out on a very negative basis, one of the things we've been told that we are, one of the advisements is we need to train our staff on the prevention of radicalisation. We're based in the Ashdown Forest in Sussex.
I used to live there. It's a very radical area. I get it. Yeah.
So you understand the demographic.
Being radicalised by the Conservative Party.
Yeah, but the problem is we're now wasting hundreds of man hours putting staff up on a recommendation that you kind of look at and you think somewhere along the line someone should be sense checking these things.
Yeah. So I can't answer that particular point. What I can say is, as I said earlier, there are some pretty good sort of moderation and quality control issues, and so I can't answer the specifics. I just don't know.
I think that's a wonderful note. No, I'm really sorry. I gave you the opportunity earlier.
Yeah.
Can you do it in 30 seconds?
I can. In the NHS contract, providers have to do prevent training all across the country.
Yes.
So that's why they've given that recommendation.
Yeah, but that's why this gentleman is saying it's not. It's inappropriate. Yeah. Yeah, we understand the reasons. But what? Yeah.
There you are.
But somebody needs to use a. Hold it, shush. Somebody needs to use a bit of common sense, and I think ending on a question that Peter can't answer, I think is a wonderful thing.
ending on the compliment of a good CQC experience is a great thing.
The point with your thing about inspection as well. If you look at the amount of work that we put in beforehand to actually provide the evidence, it made us take a look at ourselves and identify a lot of issues.
Right. If you need the CQC, if you need the CQC to make you run a better organisation,
Yeah.
You need to look at yourself.
That's what he just said.
You need to be better. Shush. We're out of time. You need to be better at running your organisation. I remember a chief executive said to me, he said, I'm so pleased the CQC came because they told us a lot of things that were wrong with the organisation. It was terrific. And I said, you know what I'd say if I was your chairman? He said, no, what I'd say? You're fine.
But you didn't listen to what he said.
I did
He
listen.
actually, said he had looked at that and he had solved it. Yeah,
I'm in charge. Yeah. Now, just for tonight. Hasn't he been a great guest? I think that's fantastic. Thank you very much. We always give our guests a little gift, which is traditional. It's a bottle of whiskey, and because we're in Positive Deviance, it's Welsh whiskey. Which is the finest whiskey that there is. I apologise to any Scots out here. It is the best whiskey, and I have to tell you, it's great for inspiration because I seldom write a word without a glass of it. So
you'll be really pleased, Roy. As a consequence of this, you will now be on the CQC register because I will have to disclose.
Exactly. No finer place can a young boy have than on your register, having bribed the chairman. Peter, you've been a great guest. Thank you so much. Thank you very much. Come and join us all. Thank you. We'll see you next time. What are we doing, John? 24th. What are we seeing? Who we got the 24th? John Ashworth. John Ashworth, who is the Shadow Secretary of State for Health. He's coming with an open mind, and he said, Roy, he begged me, he said, will you please do a health chat because we need some ideas for our Labour Party policy. What more can I say? Good night and thank you.